Thank you for coming to this PBC Symposium, New Therapeutic Options and Management Strategies in this Patient Population. My name is Christina Hanson. I'm a nurse practitioner, and I will be one of the moderators for this symposium. Welcome to GHAPP. So again, new therapeutic options and management strategies. Obviously, this is an exciting time for us in our practices and in managing patients with PBC. It's incredible to have new options, new management therapeutics in this space. And so we're going to get into chatting about that as we go along. This is our overview and target audience. And our agenda. So we're going to start out by talking about how we go about identifying patients with PBC in current clinical practice. What are the management strategies that we have for this patient population? What are the currently available therapies, which has grown? We're going to talk about PBC-specific pruritus and how we're going about managing that, which is obviously very debilitating for this patient population, and then wrapping it up with some time for question and answer. So make sure you're jotting stuff down of things that you want to talk about at the end. So our speakers and our moderators for this symposium, and I'm going to let them introduce themselves as they come up to speak. This is our disclosure slide. Additional faculty speakers. And relevant financial relationship disclosure slide. Our learner assurance statement, which I will not read verbatim. And our educational objectives. So on completion of this activity, participants should be able to describe the progression of liver disease in patients with PBC and the need to incorporate fibrosis staging into individual risk stratification. We want to discuss recent developments in the diagnosis, staging, treatment, and monitoring of patients with PBC, and illustrate a PBC treatment algorithm that provides evidence-based and practical tools for clinicians who manage PBC population. And here is our accreditation. Save some snacks for me back there. I see you loading up. Tips on claiming credit. And we'll wrap up with this as well. And you will receive an email. And then obviously educational grant support. We want to acknowledge and thank CymaBay, which is a Gilead company, for your educational grant in supporting this activity, educational activity. So thank you very much. All right, so let's go ahead and dive in. I'm going to welcome Lucy Mathew from Cedars-Sinai to start us off.
Right. Thank you. My name is Lucy Mathew. I'm a nurse practitioner. I work at Cedars-Sinai Medical Center in Los Angeles, and I've been there for 20 years dealing with hepatology patients in a variety of diagnoses. And I want to thank GHAPP for inviting me to speak, and I want to thank each one of you for being here today. So we want to talk about PBC, and I will be speaking about the diagnosis part of PBC. So some of you who have been in the hepatology world for a few decades know that PBC is called primary biliary cirrhosis in the beginning. But not all patients with PBC has cirrhosis, as we know. Therefore, rightfully, the name was a few years ago changed to primary biliary cholangitis. This is a disease of the small bile duct. Remember, there is a disease called PSC, that is a disease of the large bile duct. So PBC is the disease of the small bile duct. It has autoimmune as well as genetic and environmental factors leading to this disease. The rate of progression varies very much. It can be anywhere between like a very mild asymptomatic early disease, or it can have significantly aggressive disease with a lot of symptoms, specifically fatigue and pruritus. And pruritus can be very debilitating in some patients. Dry mouth, dry eyes, those are sometimes patients can have that. So the progression can vary. It affects 1 in every 1,000 women over the age of 40. And the serological hallmark of PBC is anti-mitochondrial antibody, or AMA, which is a very highly specific antibody, being positive in 90 to 95% of patients with PBC. As I mentioned, there is genetic and environmental factors. So patients with PBC, they're actually born with a genetic condition, and some environmental factors influence it, and that result in an immune response, resulting in small bile duct damage. So the small bile duct is damaged, and bile acids get accumulated in the liver, resulting in liver fibrosis and eventually cirrhosis. Early diagnosis of PBC is so essential because without proper treatment and proper management, PBC patients can lead to liver failure and needing liver transplant, if not death, within 10 years. And we know that when we talk about liver disease in general, 10 years is not a long time. We look at now fatty liver, look at viral hepatitis. We talk about disease of the decades. And here PBC, and in 30% of the patients with a very aggressive disease, if not treated properly, they can even progress to cirrhosis in a matter of 5 years. So it's very important that PBC is diagnosed early and treated appropriately to prevent damage and liver failure. So our typical PBC patient is usually over the age of 45. I've seen patients in their high 30s and even 40s that has been diagnosed with PBC, mostly female. The ratio is 9:1, so male can have it, but majority of the time when you think of PBC, you're thinking of a female over the age of 40. AMA, as I mentioned, is highly specific. In 40 to 50% of the time, ANA and SMA can be mildly positive. Immunoglobulin IgM can sometimes be elevated. MRCP will be normal. Remember, PSC is the disease with a large bile duct where the MRCP will be abnormal. In PBC, the MRCP will be normal. Liver biopsy is not always needed to make the diagnosis, which I will talk about in the next few slides. But you can do liver biopsies, and I will show you what exactly the biopsy should show. And coexisting IBD is also not related with the PBC. It is related with PSC. So a typical clinical presentation can vary. It can go from a normal patient who went to a routine physical and elevated liver enzyme and alk phos, ended up having further workup. And that can be that, or it can go to the other extreme where the patient complaining of severe symptoms such as fatigue and pruritus. The problem is in a 45-year-old woman complaining of fatigue, most of the time we go to, oh, you're going through perimenopausal, you have kids, this, working. So you can easily dismiss that. So very important that is why it is important that we are aware of this. And pruritus, we're thinking of dermatological issues, of course. So that's why pruritus, also the diagnosis is important. Sometimes patient can have autoimmune disease, bone density problem, high cholesterol, xanthoma, xanthelasma. Those are some of the clinical presentations where patients can come for. In PBC, alkaline phosphatase and bilirubin have a very important role. And those levels are the ones that we monitor. We need that for diagnosis, for monitoring the disease activity and disease severity, and also talking about treatment efficacy. So alk phos and bilirubin are very important. So let's talk about a case study. JJ is 62-year-old female, complains of mild fatigue and pruritus for several months. She has high blood pressure. Physical exam was completely unremarkable. Blood test showed an alkaline phosphatase elevated at 650. AST/ALT is mildly elevated into the 40s. Albumin, bilirubin are all good. So given the patient profile and the cholestatic pattern of the liver enzyme elevation, PBC is highly suspected. So we went ahead and we will do an AMA, anti-mitochondrial antibody. Of course, we will do the complete liver workup with the viral hepatitis and all the other blood tests as well too for the workup. But the first thing you think of is PBC. Anti-mitochondrial antibody, as I mentioned, is highly specific, but the titer does not correlate with the disease severity or activity. That's important to know that. So whether you have a positive AMA at 40, 160, 320, it doesn't matter. it's a positive AMA. It is the presence of AMA is what matters, that is sufficient. However, you can have, I have seen cases where an AMA is positive, but the alk phos is normal. That has happened too. And that's because we did some liver workup and we found out that the AMA is positive. That does not meet the criteria for PBC diagnosis. However, that patient is an increased risk of having PBC, so patient needs to be monitored closely and check the liver enzyme. And when the alk phos goes up, we can say that is a PBC, but not without the elevation alk phos. And as I mentioned, in 50% of the patients, ANA can be positive, and these are specific ANA, actually, SP100 and GP210. They're not readily available in the United States, but they are available in Europe, and it's recommended by EASL. But it's not, but when we might see a general ANA might be positive. So the diagnosis of PBC is established when two of the three following criteria are met. You have to have elevated, one is elevated alk phos, the second is positive AMA, and the third one is, of course, liver biopsy. You don't have to have all three for the diagnosis of PBC. So just like I mentioned, scenario one, he has an elevation alk phos and a positive AMA. Done. Diagnosis. Scenario two, elevation alk phos, AMA is negative, but positive ANA as well as SMA, then you can have the diagnosis. Scenario three, elevation of alk phos, ANA and AMA are negative, but patient had a liver biopsy, and that showed chronic non-suppurative cholangitis, intralobular and septal bile duct. So when we read the liver biopsy, make sure you need to have at least 10 to 15 portal tracts for an adequate liver biopsy. And the key word that you're looking for in a liver biopsy is, as I mentioned, chronic non-suppurative cholangitis, florid duct lesion, epithelioid granulomas, bile duct paucity or ductopenia, bile duct destruction. These are the key words that you want to look for in a liver biopsy to see whether somebody has PBC or not. So coming back to our case study, JJ's blood test showed an AMA is 640. IgM was slightly elevated at 500. Given the elevated alkaline phosphatase and the symptoms, JJ was diagnosed with PBC and no liver biopsy is needed in her case. So just like any other liver disease, the minute we diagnose a liver disease, what is the next question we ask? How much damage? Is there any damage? So just like in any other liver disease, PBC also, we made the diagnosis. So next question is, how much damage if there is any? If the diagnosis was made with the biopsy, clearly the answer is there. But if it is done without a biopsy, then we have the non-invasive testing to do that. A transient elastography or MR elastography is highly recommended. So a transient elastography, which is FibroScan or Mindray, more than 10 kilopascal, or an MR elastography more than 4.3 kilopascal is considered to be advanced fibrosis and therefore increased risk of hepatic decompensation and failure. So coming back to our case study, JJ underwent a transient elastography. FibroScan showed 10.5 kilopascal, consistent with stage 3 fibrosis. So we know now JJ is diagnosed with PBC and stage 3 fibrosis. Therefore, JJ is at increased risk or high risk for disease progression. So we need to aggressively manage her and treat her and make sure her bilirubin and her alk phos is becoming normal to prevent further progression. So Lindsay will talk about PBC treatment.
Thank you, Lucy. My name is Lindsay Yoder. I'm a PA. I work in general hepatology at Indiana University Health in Indianapolis, Indiana. Thank you for the invitation to speak, and thanks to each of you for spending the evening with us here for a little while. So no relevant disclosures, and Lucy has already got us to the point of diagnosing our patient with PBC. As I'm going to talk about the treatment, I just wanted to throw a quick slide up there to remind you of the pathogenesis of this disease. And ultimately, what we're talking about is a persistent toxic exposure to bile acid buildup that ultimately ends up leading to cirrhosis, liver damage, and can progress to decompensated end-stage liver disease. So there's a couple of different targets that the therapies for PBC can go after in the mechanism of action. So mainly we want to decrease bile acid synthesis. We want to reduce inflammation in the biliary ducts and reverse or prevent fibrosis. Treatment goals, there are a few overlapping goals of treatment with PBC. Most importantly, I think preventing the disease progression, ultimately to prevent the complications then of developing cirrhosis or decompensated cirrhosis, need for liver transplant, death, primary liver cancer, as well as we know PBC has pretty significant clinical side effects for some patients, including fatigue, or itching or pruritus. So not only preventing disease progression, but also managing those associated symptoms. These are kind of the three overlapping goals of treatment. And most of us are aware that there's been a mainstay to reduce the alkaline phosphatase, and hopefully I'm going to convince you that we're going to move more towards the ultimate goal of normalizing alkaline phosphatase, as well as normalizing bilirubin, or even further than that, reducing the bilirubin as low as possible. I think it's important when you diagnose a patient with PBC to remind them that this is a chronic, lifelong disease. And so you're going to be working with them indefinitely to provide lifelong therapy to prevent the progression and hopefully ameliorate disease-associated symptoms, ultimately improving their quality of life. So in terms of treatment monitoring, or why is this the goal? We know ALK phos is what is elevated with PBC, so it makes a lot of sense that that's the biochemical target for most therapies that we're trying to reduce. And we have data longitudinally showing the longer that you follow patients with PBC, their survival goes down, the higher their alkaline phosphatase remains. So the lower that you can get that, the better survival outcomes we have. In addition, beyond just lowering the alkaline phosphatase, we have data showing that the risk of liver transplant or death is lower the closer to normal that you can get with alkaline phosphatase. Same thing with bilirubin. More recently, we've come to understand that a goal of keeping the bilirubin normal or 1 or below is important, but there is some data also showing that survival increases if the bilirubin is actually 0.6 or lower. So these are emerging as some endpoints and targets as we continue developing and learning more about new therapies. These have strong predictors of outcomes longitudinally. And again, just a reminder, your patients can present completely asymptomatic, and that still means, you know, biochemically, we have a target that we need to go after to improve outcomes. But there are also patients that can, at presentation, be symptomatic with fatigue, itching, jaundice. They may present already with decompensated cirrhosis. However, the focus of this talk and therapies is going to be on those that are targeting the biochemical, and Anne's going to talk about pruritus treatments. And then just a note that we all probably have encountered our patients that aside from fatigue and pruritus, they tend to have a lot of other symptoms, or they certainly can. Those with the extrahepatic manifestations of Sicca syndrome, metabolic bone disease, high risk for osteopenia or osteoporosis, fat-soluble vitamin deficiencies. There are also some patient-reported symptoms that we don't understand as well and don't have targets for, those that have brain fog or cognitive impairment, sleep impairment, depression, And then certainly the direct hepatic manifestations if someone progresses to having cirrhosis. So again, with the time of this talk, we're not going to address all of these, but wanted to point out that these are things that you need to be thinking about in the overall care of patients with PBC as well. So our current treatment algorithm, we've diagnosed a patient with PBC. We've already gotten a non-invasive test or a liver biopsy if we had to. That's going to tell us their hepatic fibrosis staging. What is our first line treatment? Old faithful ursodiol, right? So weight-based dosing, 13 to 15 milligrams per kilogram per day. If they're intolerant to ursodiol, you may consider second-line therapy, very small percentage that will be intolerant. And so after you get them started on urso, assuming they tolerate that and do well, when are you going to follow up and monitor them? Probably hepatic panel in 3 months, 6 months. Some people will wait 12 months until assessing a full response to urso. I'm hopefully going to show you some data tonight that will encourage you to really consider at the 6-month mark, after 6 months of urso, whether that may be the right time to consider a second-line agent if someone has not had a full response to urso as monotherapy. So 60% of patients will have an adequate response to urso first-line monotherapy, and you're going to continue monitoring them every 3 to 6 months thereafter. And if something changes, then you might need to think about second-line therapy down the road if their alk phos were to elevate. For those that do not have a complete response to urso, which is about 40% of our patients, if they do not have clinically significant portal hypertension or decompensated cirrhosis, we have had Ocaliva or OCA around for a while, so that's a consideration. Off-label use of fenofibrate, which is a PPAR alpha agonist, is in the AASLD guidelines to be used, although it's not FDA approved for this indication. And same thing, if you start one of those second-line agents, you're going to monitor liver enzymes 3 months, 6 months, and continue to see if there's an adequate response to those or not. If you are someone who's not practicing at a tertiary liver transplant center and you have a patient without an adequate response to urso, at that point in the algorithm, you may consider referring that patient to a transplant center. And so this is the data really showing us that considering the response to urso after 6 months compared to full 12 months of therapy is probably a good idea. So of those patients, the 32% that at 6 months didn't have an adequate response to urso in the POISE trial, when you looked at those same patients a year later, almost 90% of them still did not have an adequate response to urso. So this is telling us that really most of the people at 6 months that are non-responders are going to continue to be non-responders at 12 months. So why wait until month 12 if at month 6 they're not responding? You could consider earlier at that 6-month mark to introduce a second-line agent. And then I've talked a lot about response, right? There's lots of terms we throw out there. Inadequate response, no response, good response. What do we mean by that, right? So number one, there's a lack of an agreement that exists on the exact definition of these things. There are various published criteria for what we consider to be a biochemical response. Most of us can agree the goal is to get alk phos as normal as possible. And the very bottom criteria there that's highlighted in the lighter orange color POISE is what has been used in the more recent clinical trials getting therapeutics approved for PBC. And so that's a serum alkaline phosphatase level less than 1.67 times the upper limit of normal and a greater than or equal to 15% reduction in the alk phos from the patient's baseline combined with bilirubin less than or equal to 1. So again, the old faithful urso. This is the only medication that's approved for the first line treatment of PBC. Basically, you're diluting bile acids and displacing toxic concentrations of bile acid. This was approved because of the significant decrease in liver enzymes, reducing the histologic progression of liver disease, and then improving the survival-free time before liver transplant in patients with PBC. Some of your patients may have hair loss, GI side effects like loose stool diarrhea, and about 40% of patients continue to have an inadequate response after 6 to 12 months of urso alone. A small percentage are intolerant to this medication, and then oftentimes you don't see big improvements in fatigue or pruritus with ursodiol alone. For those 40% of patients at 6 months that may not have a response to urso, a couple of things to consider are they truly adherent to the medication? If you do TID dosing, I don't know how many of you may have been prescribed 3 times a day medication, but that can be challenging, right? So if people are consistently missing one of those 3 doses per day, they may not truly be getting the therapeutic benefit. And then patients may have lived through a pandemic or life stress and gained weight since you initially prescribed their urso, and they may have gained weight and now their medication may truly be underdosed. So making sure you're hitting that 13 to 15 milligram per kilogram target is important. Making sure there is not any additional comorbid liver disease, right? MASL DMASH, alcohol-associated liver disease, an overlap with autoimmune hepatitis. There are other things that could certainly be affecting abnormal liver tests beyond a pure non-response to urso, and those should be considered and ruled out. And then because pruritus is so prevalent in patients with PBC, if they've been prescribed cholestyramine, they're not taking that correctly and they're taking that with their ursodiol, you may not be getting that full therapeutic effect. So going back to JJ was appropriately started on first-line urso treatment at a dose of 13 milligrams per kilogram. It was well tolerated, and then after 6 months of therapy, the ALK phos was rechecked and still 480. Happily, still a normal bilirubin, but JJ would be considered a non-responder to urso, and this is the point in time where we want to think about an addition of a second-line therapy. Because JJ is tolerating urso, you're going to continue it. And the second line therapies would be in addition to continuing ursodiol. So this is a little bit of a treatment algorithm graphic that's different than that first one, but the red circle is showing you where we are in this pathway, right? JJ's had an incomplete response. So now we're going to talk about the newer second line therapies that have been approved. Well, first talking about the one that's been around for a little while. So Ocaliva, or obeticholic acid, or OCA, is an FXR agonist. There are these receptors in other places outside of the liver, but essentially this is inhibiting bile acid synthesis and increasing bile acid secretion. This was approved under accelerated FDA approval in 2016. It's approved to use in combination with urso for those that have had an inadequate response to urso alone, or if they were intolerant of urso, it can be used as monotherapy. The POISE trial was double-blind, placebo-controlled phase 3, and after 12 months showed efficacy and safety in patients who had these parameters. They use that endpoint of ALK phos less than 1.67 times the upper limit of normal, reduction of at least 15% from baseline of the ALK phos while maintaining a normal bilirubin. Notable safety concerns: new or worsening pruritus in a disease that can manifest oftentimes with pruritus. So literally a difficult pill to swallow, pun intended. Worsening fatigue, right? And then 15% had an inadequate response to Ocaliva. 10% of patients discontinued this within a year because of pruritus. And then this is contraindicated in patients with decompensated cirrhosis or those with clinically significant portal hypertension. So this led to the label change in 2021 after more real-world experience, where we realized that there were increasing negative liver-related outcomes in those that had clinically significant portal hypertension or decompensated cirrhosis. So you should not prescribe Ocaliva to patients who have clinically significant portal hypertension or decompensated cirrhosis. And also a recommendation to start this at that lower 5 milligram dose once daily, assess for tolerance before considering to increase that after 3 months to 10 milligrams. So newer and different class of medication that signal or that work on slightly different mechanism of action through the PPAR signaling axis. We have had off-label use of fenofibrate in the AASLD guidelines for a while. And now we have 2 additional second-line treatments that were just approved earlier this summer. So elafibranor came first. This is a dual PPAR alpha and delta agonist. This got accelerated FDA approval in June of this year. This again is to use in combination with urso for those who have had non-response to urso, or if they were intolerant to urso, you can use this as monotherapy. The ELATIVE trial is the double-blind, randomized, placebo-controlled trial that met the primary endpoint of alk phos less than 1.67 times the upper limit of normal, a change in greater than or equal to a baseline alk phos of 15% while maintaining a normal bilirubin. So you can see the primary endpoint was met there at 52 weeks in 51% of patients that were treated with elafibranor compared to 4% of the placebo. And then about 15% of patients actually had a complete normalization of their alkaline phosphatase at the end of the study. The second line therapy to get approved this summer was seladelpar. This is a selective PPAR delta agonist. All of the things as far as the accelerated approval, who and when you should use it are the same as what I just mentioned. But this was the response trial. So slight differences here. 61.7% of patients met that primary endpoint of the alk phos reduction below 1.67 times the upper limit of normal, compared to 20% in the placebo group. And then 1 in 4 patients, or 25%, had a normalization of their alk phos, compared to 0 in the placebo group. With elafibranor, there was a trend toward a reduction in pruritus. However, that was not statistically significant. A slight difference in data reported here for seladelpar was there was clinically a statistically significant reduction in pruritus. This was seen as early in month 1, and this was maintained throughout the end of the trial at week 52. And then there are other targets of PBC therapies that are continuing in clinical trials, and we may have future new different therapies that come out. For right now, it's been exciting this summer to have 2 new second-line therapies approved. The data is here. I don't know that many of us yet have any or enough real-world experience to share, and time will tell as we continue and start prescribing this. We need to rely on everyone to share real-world experience as we continue to come together. So going back to JJ, thinking about second-line therapy 6 months after there was a non-response to urso, we could consider elafibranor or seladelpar as the next second-line agent. We would want to continue monitoring those labs every 3 to 6 months. Some other considerations are, because there was mild transaminase elevation at the beginning of the presentation, knowing if those have dropped, or again, we need to consider potential overlap with autoimmune hepatitis. And then because JJ was identified as having advanced fibrosis from that liver stiffness measurement on FibroScan, that's something you'll want to continue to closely monitor with non-invasive testing every 6 to 12 months. And as JJ had some pruritus, we can stay tuned and see if JJ had an improvement after starting a second-line agent. And Anne is going to tell us more about what else we can do for pruritus and PBC. Thank you.
Great job to both of the speakers, and thanks to GHAPP and to Gilead CymaBay for having me speak today. My name is Ann Moore. I'm a nurse practitioner at Arizona Liver Health, and welcome to the Itchy Scratchy Show. For the next 10 minutes, I'm going to be talking to you about managing the itch in primary biliary cholangitis. This is really an important topic that 10 minutes does not do justice to. This symptom is a plague for our patients. These are my disclosures, please ignore. So I don't know if you all are familiar with Dante's Inferno. It is about the relentless itching in hell. So the eighth ring of hell is where people suffer from the burning rage of fierce itching that nothing can relieve. And I feel like this is where some of our PBC patients live their lives. And if you've ever itched, you can relate. And, you know, we worry about targets for PBC treatment, and that's where we focus. But you can never leave the patient behind when you're trying to hit a treatment target. So please know that 70 to 80% of our patients itch, and you would not want to live your life in the eighth ring of hell along with our patients. So anyway, just some random facts about pruritus and PBC. 70 to 80% of PBC patients report pruritus, up to 18% severe. Pruritus is not correlated with disease severity. It's not unique to PBC in liver disease. Many of our liver disease patients itch, but it does appear earlier in biliary diseases. It can be localized or diffuse, but it has a predilection for the palms and the soles. There's typically no primary rash, but if you look close enough, you may find secondary skin lesions from scratching that look like excoriations, red crusted bumps, and darkening of the skin. So you can tell the history of a PBC patient's pruritus with a good dermatologic exam, oftentimes. Intensity of itching typically is worse in the evening and at night. It is exacerbated by heat, pressure, and stress. Up to 74% of patients report disturbed sleep. When sleep is disrupted, life is disrupted. And so you get into this vicious cycle of fatigue and itching that just seems never ending for some of these patients. It can cause social isolation. People are actually embarrassed to be out in public and scratching. You know, they're looked like, what is going on with you? It can cause depression. It can be variable in course, intermittent, progressive, or self-extinguishing. So, big surprise here. Hepatologists are not great at addressing itch. So this little study looked at number of notes documenting pruritus and then by specialty. We should be addressing itch every time we see a PBC patient. I would hesitate to guess that if we added APPs and GI and hepatology to this, we'd be doing better, I'm hoping. So what about measuring pruritus? In the background of clinical trials, there's many scales that we're using. How does that translate to real world practice? Me personally, I don't believe it does. But what we can learn from the instruments we use in the clinical trials is how to question a patient about itch. How do you approach a patient to learn, to get them to disclose to you what their itch is like, how severe it is, how is it impacting their lives? So I would encourage you to look at the scales, look at what they assess, and then maybe incorporate some of the language into your practice if you're not actually using a scale to track the patient's pruritus. So the itch in PBC is complex and we don't fully understand it. It's an interplay of modulators, including bile acids, bilirubin, lysophosphatidic acid, endogenous opioids, serotonin. Now in the background of clinical trials, we're looking at IL-31, which is associated with itch sensitivity, which is pretty interesting. You can measure the levels. As the levels go down, pruritus it typically is getting better. So that's kind of an exciting finding, not commercially available yet. But I feel like we have better ways of measuring response to treatment than we ever have before. So one thing I'd like to suggest is don't talk to your patients about itching if you're not prepared to come with a solution. at least try to help them. Like, you can ask about itching, but if you're doing nothing, it's very frustrating. So ask, but be ready to treat. And you should ask at every touch of that patient. So what about for your patients who are like, I'm itching, I'm miserable, but I'm not taking another medication? This is very common in my clinic. They're being driven crazy, but they don't want to add another medicine to their regimen. So what can we do for those patients? Here's just a hit list of maybe things you can try. Some of them work, some of them don't, combinations of things. So loose, soft clothes, gloves, like cotton gloves and socks, thin cotton gloves and socks at night after they've moisturized, because remember, it's palms and soles that typically itch. Frequent use of emollients. I live in the desert, like it is dry in the desert. People itch without PBCs. So, I mean, hydration and use of emollients like Sarna and CeraVe. Avoidance of precipitants is important. So narcotics, heat, smoking, scented soaps and laundry detergents. Also telling patients to trim their nails, like very short. That seems like, you know, kind of should be like just second nature to do that, but a lot of them come in with long pointy nails. That's kind of the thing now, and they can really make for some nice excoriations. So trimming nails is important. A cool but not dry environment, cool showers, not hot. Cool packs applied topically to the skin can be helpful. Controlled sun exposure and UV light exposure is helpful for some patients. I know I said these patients don't want to take medicine, but how many of your patients don't consider herbal supplements as medications? And they'll be like, I'm not going to take a prescribed medication, but what herbal supplements can I take? Well, it turns out there's a few that I find helpful in PBC, and probably the one I turn to the most is primrose oil capsules. Obviously, this is off-label, but a gram 3 times a day does wonders for a lot of these patients. I use it frequently. Dandelion root, topical peppermint oil. So if you're adding an herbal supplement, what are we going to look for? Dilly. Not common with these medications, but I feel whenever I order an herbal supplement that it is, or prescribe an herbal supplement that's not I need to follow for dilly just because it's not well regulated, right? So we don't really know. We think we know what's in them, but we maybe not. So I'm always watching labs just in the background. And then there's the over-the-counter antihistamines, which really aren't helpful for itch and PBC, but they are helpful for sedation in some patients. So it may help them to sleep. So, okay, your patient has exhausted all the non-prescribable possibilities and they're like, I cannot take this anymore. What are the next steps? So these are the various classes of frequently prescribed medications for the treatment of pruritus. Not any of them approved by the FDA except for cholestyramine for itching in cholestasis and their mechanism of action. So you can see where they hit various targets. I'm not going to go through this all because I only have 10 minutes to talk to you, but it's fairly interesting. And you know, there's some things that you may not have thought about in terms of like ondansetron, which serotonin is a known pruritogen, and if you suppress the 5-HT3 with ondansetron, some people have relief of their itching. So what works for one may not work for another. So please, if you try something and fail, don't give up. Try something else because you may have success with something. You can have your one go-to, but if it doesn't work for that patient, please look at the other choices that are available out there. So this is the stairway to pruritus relief. I don't care if you start at the top of the stairs, the bottom of the stairs, or the middle of the stairs. You can start anywhere you want on this list. It's your comfort level. And after your discussion with the patient about what they would like to try, then you can go for it. I mean, I have a personal favorite. We all sort of get comfortable with various things to prescribe, right? And it's all, you know, I figure in a GI crowd, where are people going to start here? It's going to be at the bottom of the stairs with cholestyramine. And it turns out that that is the only FDA-approved drug for general cholestatic pruritus in the United States. Obeticholic is FDA-approved in pruritus for PFIC, and maralixibat is FDA-approved for inalagille syndrome. I think in refractory pruritus, we could potentially think about that. for our itchy PBC patients, but everything other than cholestyramine that you see on this slide is off-label, right? So I can tell you what my hit list is, and I'm a naltrexone fan, so I jump right to there. And you can see the various doses and the side effects associated with all these medications. I think some interesting things in the experimental approaches, gabapentin helps some patients. There is absolutely no data clinically to support this for itching, but I've had it anecdotally work for my patients. I think phenobarb I don't use because it's so sedating, but it might help for sleeping. I'm just afraid people wouldn't wake up. Ondansetron is there, 4 to 8 milligrams twice a day. I typically use the higher dose. And then, of course, if your state is one that has medical marijuana, many of my patients have told me that cannabinoids are very helpful, and if not with itching, with sleep. So there you go. I mean, I would say with rifampicin, please watch your liver enzymes, watch for hepatotoxicity and renal dysfunction. Bezafibrate, which is spelled wrong, sorry, is not approved in the US, but fenofibrate is, and many of us use that. Again, monitor liver and renal function. You know, you're not going to start one of these medicines and not keep following your patient, right? And the important thing here is follow up after you start a new agent. Don't start something and forget your patient and see them in 3 months and it didn't work. Like, you have to do a televisit, check back in with them after a couple of weeks to see how they're doing. If it didn't work, you can add or you can go on to the next thing, right? So I just wanted to, I mean, this is a very busy trial, a very busy slide, just showing you the clinical trials that are happening, have happened in the last 5 years in agents with regards to itch and cholestasis. And I think many of the targets were in the last slide. We have opioid agonists, and we have the PPARs, and in fenofibrate, we have SSRIs. The N's are all small, and they're not going to get us to FDA approval, anything. We need new meds that are available in the first line therapy patient to help them with their itching. I mean, we can continue to prescribe off-label, but it would sure be nice to see some more data so that we can reliably help our patients treat their itch. So here's the IBATs, additional PPAR. We know that these targets can help. We just don't really have the perfect drug or combination of drugs yet. So now we're down to guidance. So if you look at the ASLD guidance, this is kind of what they list in terms of bile acid sequestrants, rifampin, naltrexone, sertraline. I think SSRIs are a good start. Many of our PBC patients are depressed. And I would say with all of these itching agents, we tend to start low, but you really need to optimize the dose to see if it's going to work. So I fully agree, start low, check for tolerance, but then try to push the dose up to a level that is going to help the patient. That's especially true with cholestyramine, which oftentimes you can't be successful because of the associated side effects with cholestyramine. They're either going to get diarrhea or constipation or bloating and they don't tolerate it. But you're probably not going to get anywhere if you're giving 4 milligrams of cholestyramine daily. You really have to hit the dose. The same as with sertraline and naltrexone. Start low, amp up as tolerated to the max level that you can, and then go from there. You're much more likely to be successful. So JJ was started on cholestyramine, surprise, to control the symptoms of pruritus in parallel to her UDCA treatment. So now we're going to look at itching in our treatments for PBC. So what is the effect of urso on pruritus and PBC? Turns out none. In this study of 214 patients, it was no better or worse than placebo. Not surprising. But what about our second line therapies? Now, obeticholic acid gets a bad rap for itching, right? But I want you to look at this POISE data. This is 52-week data, where while it didn't improve itch, it also didn't worsen itch. In the placebo arm, the titration arm, which went from 5 to 10, and the OCA 10 milligram arm, which we know was a big mistake to start at 10 milligrams, but their baseline itching was equal to their 52-week itching. And this has been shown again in the 5-year data from the open label trial. So I know you're thinking itching. While itching does not improve on OCA, there's no doubt. We have data that shows equal at the beginning and the end. Patients with PBC itch, I just got done telling you 70 to 80%. So this is a natural history of disease. Yes, there is itching associated, but it tends to ramp and then go back to what their baseline is. So, but we have 2 new choices in the world of PBC, and this is the results of the ELATIVE trial with pruritus reduction in elafibranor. So while there was a trend towards improving pruritus with elafibranor as measured with the NRS scale, from baseline, the results were not statistically significant, and therefore these results are only descriptive by nature. They also saw a nice improvement using the PBC 40 itch tool and the 5D itch score. And I think there's going to be more data surrounding their itching results to come at ASLD. So what about results of the response trial for seladelpar? And if you'll, in the bottom left is the pruritus data. And they did note a significant improvement in pruritus on the NRS scale with seladelpar, which lasted through month 12. So these 2 new drugs are very encouraging for our patients with PBC. However, they're second-line therapies. So you can't forget about what I just told you about treating itching, because these drugs aren't going to be an option until I feel like there's going to be pushback. And while we know we see most response to first-line PBC treatment at about 6 months, 6 to 9 months, the guidance still says evaluated a year for second-line therapy. So while we know we should be evaluating probably earlier, we are probably going to be stuck with first-line therapy in some of our patients who are inadequate responders. And then we don't have the option for a while. And if a patient is itching, you need to not wait for second-line therapy that you think will be helpful. You need to look back at the other options that I was just telling you about. So what about seladelpar and pruritus in their ASSURE open label study that looked at long-term safety and efficacy of seladelpar in PBC patients? Well, in the 60 patients with moderate to severe pruritus at baseline with an NRS score of 4 or higher, rapid improvement was observed at month 1. And by month 6, the patients reported a mean reduction of 3.5 points. And this impact was sustained through months 12. So this data was presented at EASL. There's probably newer information now. What's the Hail Mary when medications fail in PBC? Well, fortunately, I don't see this very often. But, some patients are literally driven crazy by their itching, and you have to do something. And so at tertiary centers, there's sometimes the option for MARS or plasmapheresis. I've never seen nasobiliary drainage done before, but it's an option in our itchy patients. And then I think liver transplant for refractory pruritus with exception points may be an option in some areas of the country, but not all. But I think if you endured the itching that some of our PBC patients go through, anybody would be, you would be up for anything at this point. So, and lastly, I'll leave you with this thought that happiness is having a scratch for every itch. And please, please, please think of quality of life in your PBC patients. Don't just think about treatment targets, and help them scratch their itch. Or help them not scratch their itch. Thank you.
Okay, thank you all 3 for some excellent talks, really wonderful presentations. We'll open it up now for any questions. There are 2 mics in the room, so.
Is it on? Oh, sorry. Can you talk a little bit about bone density screening? You mentioned osteoporosis. If we're talking a younger patient that's not postmenopausal or even close to that.
So, whoa. Hello. So any patient with cholestatic liver disease is at risk for bone loss. And so recommendation, no matter the age or the other risk factors, is for a bone density at baseline, and then every 2 years, depending on the results of that, that initial scan. And you can get that approved through insurance just by making that point in your note.
Hi. Can you continue to have, or can a patient continue to have pruritus despite normalized alk phos?
Yes, absolutely. Oh. So PBC associated symptoms are still present oftentimes with normalization of our targets. So yes, it's not about the alk phos in these patients. There's other things in action. So absolutely, we see itching continue despite hitting those targets.
Hello. In monitoring the alk phos, and someone who's receiving treatment and the alk phos is not improving with ursodiol, for example, and you fractionate the alk phos and it turns out to be more intestines or bones, what do you do then?
Somebody else answer. Go ahead.
This is a patient that has a diagnosis of PBC. I would still continue to consider second line agents to drive that alkaline phosphatase down if you have second line agents that are available to you.
I feel like it's not common for us to find other bone or intestinal, bone sometimes, intestinal sometimes, but this is primarily going to be related to liver disease. If you're finding something else, then obviously pay attention. So if you have someone with osteoporosis who's had a recent fracture or whatever, like you have to pay attention to the alk phos, but most often when a PBC patient is not responding to therapy, it's because they're not responding to the PBC treatment. I know, there's other potential like factors that weigh in here. We see alk phos elevation in patients with MASH, for instance. And so that's always in the back of the mind. But treat those other issues as you would. If you find bone, obviously you're going to treat their bone disease. That may not, rebalance, but I still feel like the patient deserves to be treated as though they're having progressive PBC until proven otherwise. You have non-invasive testing to monitor that. So you would not expect improvement in someone that had an elevated alk phos. And if you do, and you're seeing bone or intestinal alk phos, then maybe that's there. But I think that is the zebra in the room and not what we see typically.
All right, one last question over here, and then we're going to have to break.
Okay.
Have you seen any correlation from patients who have had cholestasis during pregnancy and develop PBC in the future?
I feel like that patient would be somebody who may have a PFIC mutation, or one of those, and you could do a genetic cholestasis panel, which is available for free, by the way. Talk to your Ipsen rep. But that would be, I would see that more likely to be associated than a PBC, although it is not unheard of for a patient. I have seen PBC in a patient who had previous itching and cholestasis during pregnancy. Not often, but I'd lean towards the genetic mutation.
Okay, once again, thank you to our excellent speakers. Thank you for attending. Have a great rest of the course.